It is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. If you didn't know it, that was the amazing Phil Collins and his immortal rock and roll group Genesis. And if you haven't guessed it or don't know it for sure, today will be Phil Collins Day. All our music will be from this great British entertainer. Hi, I'm Dr. Minarsik, and today is Tuesday, April 17th, and this will be our 60-second full 2-hour session in global medical school pathology. It's 9 o'clock in the morning here in Chicago. We had some horrible winds yesterday, but it looks like it's going to be better today. It's still chilly, but very, very sunny. And I guess you know the drill. This is a good time to do our test now. So I'm going to be asking you all, can you hear me? Great, looks like you can. And the second question is, what do you see on your screen? I'm not too sure what it is. It looks pretty horrifying. I think it's in class reptilia, and I certainly wouldn't want to come in contact with him, although he does look kind of cute. Okay, we're done with our test, and I want to make a few small announcements. The big announcement, which is the one I've been harping about for the last several weeks now, is all of our movies are finally up. So if you go to medicalschoolpathology.com, and I hope you've been there already, and then click on the archives button for this year, you're going to see 61 sessions, full 2-hour sessions. Almost all of them are in the high resolution, high definition, high audio, high video, MP4 format. There's a couple that are WMV or FLV or MOV, and they're not as good quality as most of the others, but the vast majority of them will be better quality viewing the movies than attending the live session. And that's because when I record these things, I record them from my end before it goes over to you on the internet. So I'm really, really proud of those movies. I've been working hard on them, and I want to thank Alex, who has helped me and given me some advice, who may even be here today. I also promise you that every session from now on, we only have a few sessions left, by the way, in case you haven't figured it out, every session now will be up, let's say within 3 or 4 hours after the session is over. So as soon as this session will be over, what I do is I take the movie, I format it, I compress it, I upload it, and that used to take a lot of time, but I got myself a new supercomputer that will speed things up a little bit. Okay, next announcement is we're almost done. I guess I could show this to you for a second, just it'll help me get my bearings straight, but here's where we are, folks. We are right here at female now. Okay, now it's a pretty long chapter, I'll admit that, and even endocrine is medium, skin is pretty long, bone is sorta medium, neuropathies, myopathies are short, CNS we have done already, and I is a movie that my son has already made. So in all practicality, we have female and breast, endocrine and skin, bone, nerve, and muscle. I could probably do that in about 10-12 sessions. Now the fact is, we have 14 slots open until June 1st. So almost certainly will we be finished by the end of May. And if you remember, if any of you attended this course last year, we also finished by the end of May last year also. So I'll have June, July, and August to goof around, enjoy the summer, take bike rides, go kayaking, and then come back in September with a brand new session. But the reason why I did it again this year is to make much, much higher quality movies. And you're going to see those movies if you download them. They're really, really great. Okay, and also don't forget, at our very last session, we're going to have a graduation ceremony, and Dr. Vinay Kumar, the author of Robbins, will be delivering the keynote address. He will be here in person. Okay, no other announcements left. So let's talk about the personality of what we're going to do today. If you remember, we've been spending a lot of time finishing off that male reproductive system, male genital system discussions, which really boil down to diseases of the penis, diseases of the prostate, diseases of the testicle. We have done everything to finish that chapter except for lab. So in the first part of the first session today, we're going to look at a few, not too many, I would think maybe about a dozen slides, a couple from penis, couple from prostate, a few from testis, and we're going to go into the lab and zoom in on them and just show you the salient features of the general normal and abnormal tissue features of various diseases. That will not take the whole hour, I hope, but it might. What we'll do in the second hour then, and maybe even the second part of the first hour, is then start a brand new chapter on female reproductive system. And I'll say a word about that now. Everybody likes female. It's a great chapter. Like male, it's very graphic, it's very logical, and also it's really quite long. You know, women, they say, talk a little bit more than men do, so this is a considerably longer chapter than the male reproductive system. And I'm sorry if I made a sexist kind of a statement there, but it's a long chapter. It's been decaffeinated significantly. It's very logical, it's very graphic, and I love it a lot. So let's go to lab. Now that we have said we're going to do lab in the first half, and even though we discussed a lot of general features in diseases of the male reproductive system, it really boils down to these three things, doesn't it, in terms of practical human diseases. And might as well start out with penis, because that's where Robert started out. And I guess a very good place to start out is normal histology of the penis. So that's what we have here. And you will see it in about, maybe 3 seconds, 2, 1, and I know you all see it now. And if you're thinking that this epithelial lined structure is the actual spongy urethra within this erectile corpus spongiosum, you're absolutely right. And we discussed before whether the urethra is lined by sort of squamous or transitional epithelium. I said I like to call it transitional. I know some of the purists would like to call it something else, but take a look. It's stratified. It looks like it might be a little squamous, I guess. It flattens out, but it certainly doesn't keratinize. And here you have a couple little mucus glands called the glands of Littré, secreting mucinous, very mucinous substance in the urethra. And then here you have these spaces. They're vascular slit-like spaces, and it looks like there's a lot of either muscle or fibrous connective tissue around them. And if you look at these slit-like vascular spaces, this erectile tissue, and then that you went back and looked into the corpus cavernosum, which you're going to see up here, it pretty much looks the same. It's slit-like spaces. There's a lot of smooth muscle fibers. There's a lot of these open vascular channels, and this is the erectile tissue. I don't know of any primary diseases of erectile tissue. I know you can have fibrotic responses of them, and I've also never seen personally a tumor of the corpus spongiosum urethra either. However, I guess it's possible, and if a tumor did arise from here, you would call it probably a squamous cell looking carcinoma. You know that the primary inflammatory diseases of this urethra are often sexually transmitted diseases, GC at the top of the list, chlamydia. I guess some of the gram-negative enteric infections are possible. And this is all we're going to have to say. Take a quick picture of this in your mind, because it's a great shot. You can see bands of fibrous tissue separating the spongiosum from the cavernosum. And let's get into a couple of diseases now that we have a good feeling for the normal in our mind. And of course, I think this is probably this is something we talked about, and I think you'll probably recognize it right away for those of you who have been enjoying the labs a lot, because what you're going to see now, maybe in about 5 seconds, because this is a rock lab slide. This is not an FPX slide, so it'll take a little bit longer to load. But I feel quite sure that in a very short period of time, you will see something. I know you don't see it yet because I don't see it yet. So let's be a little more patient. Get the slide under the microscope. And here we go. I'm guessing you can all see it now. Is that correct? Yeah, everybody sees it. So you know this is skin. You know that this is not only squamous mucosa, you know it's skin because there's a stratum corneum. And I bet you, if you looked pretty well, you'd probably find some skin appendages too. But you can also see that the deep edges of this skin are marked with India ink as well. I'm going to zoom in on that a little bit. And the reason why they're marked with India ink is because this was a resection of a skin condition, or perhaps you want to call tumor. So obviously the surgeon or the urologist wanted to know if the condition that's on the epidermis here has involved the deep margins of his surgical excision. So there's your India ink. And here's the epidermal surface. And you can see there's a stratum corneum. And remember, not everything that has a stratum corneum or a keratinized surface is skin, but it usually is. You know, the hard pallus is keratinized, but I bet you if you look around you'll find some skin appendages. Not in this field, however. And you can also tell that this is not really totally normal skin either. It looks like it's a little thickened. And let's zoom in on some of those thickened areas. And it's getting a little bit slow in focusing because the bandwidth from our internet microscope is interfering with our webinar bandwidth. But this is all I really wanted to show you. And now, not only do you know that this is not normal skin, but I think you could see that there are some very atypical, dark, or what we call hyperchromatic, and pleomorphic or significant variation in size, as well as an increased number of mitosis, of which some of them are abnormal. However, the one thing that you will agree with is that the basement membrane here, you can almost drive your segue through it because it's a nice sharp margin. Now you know that's just a digital artifact there. Anything that's that straight has to be an artifact. So you can see we have a lot of atypical cells in the epidermis. You can see that they are very atypical, but you can see that in all of the sections which we look at. And here, we'll look at another one here too. This might take another second to focus, but we'll look at another area. And I think you'll agree that whatever this process is here in the epidermis, these dark atypical cells, they stop dead short of the basement membrane. Okay, so please, why somebody just put me out of my misery and give me a diagnosis so we can move on. Yeah, this is very severe dysplasia. I think it's so severe you call it carcinoma in situ. And carcinoma in situ of the skin of the penis, just like carcinoma in situ of the skin in many other places of the body, is called Bowen's disease. So this is Bowen's disease of the penis. But Bowen's disease as carcinoma in situ can appear in many other areas of the body. And it doesn't infiltrate. If you even saw one tiny little nest of cells breaking into that connective tissue, you would no longer call it Bowen's disease, would you? You would call it invasive. Okay, but so for somebody to call this Bowen's disease, it means they had to spend a lot of time looking at many sections and making sure that there were no areas of invasion or infiltration. Okay, now I'm going to show you another tumor of the penis, and I think you'll probably get this right away, almost as a knee-jerk reflex. I think we'll even have a gross picture of the gross specimen here as well. And let's give it a second, and I'll click on that. You'll probably see something pretty quick. See, when we do the virtual microscope, it interferes with the bandwidth, so it's a lot slower than if I do it without webinar. There's the specimen. You could see the skin of the penis, you could see part of the glands, and then you see an irregular large structure here, which is more than just a thickening of the skin. It looks like there's a good growth. Here it is on a cut section. You could see parts of the fascia of the penis surrounding the various erectile structures. And I think you already know the diagnosis without looking at it under the microscope. And you probably hope you're not peeking, but you know what this is, right? This is an infiltrating squamous cell carcinoma. And I'm going to show you the microscopic now. And like any other squamous cell carcinoma of the lung, of the esophagus, of the oral cavity, of the skin, it is going to look very much the same. Now you know these are your erectile vascular channels again. You know that up here you have what is probably some remnant of relatively normal skin, and you can see up here on the right some remnant of normal skin, but in the middle it looks like there's sort of an ulceration and there's a disruption of this normal thing, and I'm going to zoom it in a couple of clicks. And maybe even one more click. And we're going to wait now for about 3 seconds for it to focus. And at this point, I'm going to have to ask you the most obvious question in the world. You know what? Everybody has feelings. My feelings are not going to be hurt, but I have to ask you, can you almost instantly, as a knee-jerk reflex, recognize this as an infiltrating squamous cell carcinoma? Okay, most people are saying yes. And look, and I like the person that said, of course. But look, if you saw a little whorled structure like this, or a whorled structure like this that's infiltrating, what would you call that? And everybody knows these are pearls. Now, if you see a pearl, or a lot of pearls in a squamous cell infiltrating carcinoma, would you call that well, medium, or poorly differentiated? So is a squamous cell carcinoma with pearls probably going to behave a little bit better than a squamous cell carcinoma without pearls? Absolutely. If it's poorly differentiated, not only do you not see pearls, but you might even have a hard time recognizing these as looking squamous as well. Okay, we're done with that one. Thank you, thank you, thank you. Most of the rest of the cases are not from our Rock Lab. Here's something I labeled EQ, and I debated whether I should show it to you, but I did mention it in our discussion that there is another pre-malignant condition of the skin of the penis called erythroplasia of Queyrat. Q-U-E-R-A-T, I think it's spelled. Funny name. I don't know who Queyrat was. I guess I could have looked him up. But take a look here. I think you'll agree that this skin is not growing in a normal fashion. There seems to be a relatively disorderly pattern of maturation from the base of the epidermis towards the surface. And in addition, I'm going to zoom it in even more. For those of you who are non-believers, don't you also see that there are a lot of atypical looking cells here as well? Look how big and dark that one is. It doesn't look quite as nasty as our Bowen's disease. Look, there's a mitosis over there. It doesn't look quite as nasty as our Bowen's disease, but this is also pre-malignant. Now, I know what you're thinking. You're thinking, well, why do they have to make up all these fancy names? Why don't they just talk about the big process? If both of these are dysplastic epidermis, which can lead to squamous cell carcinoma, including in situ, why not just call them one word rather than two? And I agree, but I just want to let you know, this almost has more of an appearance of a basal cell carcinoma than a potential squamous cell carcinoma, but it hasn't infiltrated either. So I think one reason why it's probably not called a basal cell carcinoma is because basal cell carcinomas are only on sun, or primarily on sun-exposed skin. And I don't think there are too many people that walk around with a lot of sun exposure on their penis. If they are, they're probably in jail right now. But let's just say erythroplasia of Queyrat, functionally speaking, is another type of premalignant squamous cell condition of the skin of the penis. And whereas Bowen's disease could be anywhere in the body, erythroplasia of Queyrat is only in the penis. Last penis case, something you may not see, something I have not seen too much of myself, but you could not ignore it. This used to be one of the most common penile skin lesions of several generations ago. You know this is skin because you could see hair follicles, you could see sweat glands up here, but you can see a lot of inflammation as well, can't you? And it looks like that there's a lot of inflammatory cells in that papillary dermis primarily. And I bet you if I asked you, are these lymphocytes or are these neutrophils? From this power, I know what you're going to say. What's the answer? Are these monos or polys? Yeah, you're all saying lymphs. Well, guess what? You're wrong. These are primarily plasma cells, which look like lymphocytes, and they are derived from lymphocytes. But the reason why I want to point out the word plasma cells is, you know, syphilis, especially secondary syphilis. Of course, the chancre is primary syphilis, but in secondary syphilis, there is a wide variety of inflammatory skin lesions, and for some reason, the primary inflammatory cell is the plasma cell. And that's also true with the chancre as well. So I'm going to go in a little bit deeper here where you can see probably some nice inflammatory cells. And I want to point something out. You see, that's a plasma cell, that's a plasma cell, that's a plasma cell, and I'm going to show you another area perhaps where we could see them even better. Let's move on to the next peg over here. You see that? That's a plasma cell. That's a plasma cell. And the reason why I know that's a plasma cell, that's a plasma cell, so at least half these cells are plasma cells. So whenever you see an inflammatory skin lesion, that's primarily plasma cells. You know, the first thing most pathologists think is secondary or even primary syphilis. The reason why I know these are plasma cells is because the cytoplasm is oval, the nucleus is round but off to the side, and there's a little clear area or Golgi or Hoff or whatever you want to call it between the nucleus and the wide end of the cytoplasm. And look at, there's probably the most classical plasma cell you'll ever see, and there's another one, and there's another one. And by the way, you see this cell down here that my hand is on? What kind of cell is that? Yeah, everybody knows it's an eosinophil. Look how nicely it stays. But there's only one. Most of these are plasma cells. Okay, we're done with penis, and let's move on to the prostate. And we discussed a lot about prostate. We said that the primary diseases are inflammation, benign enlargement, and malignant tumors. So here's the world's most normal prostate. And I'm not going to say much about it. I want you to take a quick picture here. See all of these nice glands? See how they're generally growing in a nice, orderly fashion? Here, I'm going to zoom in Kansas over there. Do you see how in all of these glands the nuclei are towards the base, and every little glandular acinus is separated by a little bit of fibrous tissue from another one? Do you see how most of these cells do not have nucleoli? You can see some secreted material. You know that when this secreted material hardens, they call them concretions often, or corpora amylacea. And this is, as a quick picture, what every pathologist would call absolutely normal without even blinking his eyes. This is a classical thing. Okay. Now, let me ask you this. Let's say that you had a lot of neutrophils infiltrating between these glands. What would your diagnosis be? Let's say you had a lot of lymphocytes infiltrating between those things. What would your diagnosis be then? Okay, so the first one was acute and the second one was chronic. Now, in which type of prostatitis would you be most likely to culture bacteria, acute or chronic? And the next question is, would the bacteria generally most likely be in the family of gram-negative enteric bacteria like E. coli, Pseudomonas, blah, blah, blah? Yes, absolutely. Okay, let's quickly forget this picture of the world's most normal prostate and look at the next slide here. Once again, I think you'll agree that this is a glandular structure. And I'm going to move into an area here, like here for example, and I'm going to say if this was the only thing I showed you, you probably not even blink your eye and you'll call it a normal prostate. Or maybe you might want to call it hyperplastic, I don't know. By the way, what is this little pink thing over here? And over here? Yeah, it's a concretion. I think they're called corpora amylacea. You're saying both of them. Okay, now let me ask you this. Are these sort of normal or perhaps hyperplastic glands infiltrated by inflammatory cells? Yes or no? Oh, come on. Most of you are saying yes. I don't see a single inflammatory cell here. No. This is a fibrous tissue, perhaps a little smooth muscle. But here, before you answer that question, let me show you another area on this prostate, which we're going to look at right here. And let's look at this area here, these glands. Now, my question is, again, are these glands infiltrated by inflammatory cells? Absolutely. Now, without zooming up the microscope, what are all of these cells here where I'm drawing the circle? Yeah, they're acute, they're neutrophils. And by the way, you see these cells down here? I'm drawing the circle down here. What would you call those? Probably lymphs. So what do you want to diagnose this prostate as? How about acute and chronic prostatitis? I see a couple of you have said it already. I'm very proud of you. And let's move on. Here is something that I labeled BPH. So I think you probably know what this is. And not only are these glands a little bit hyperplastic, but do you see how they occur in nodules? Do you see there's a little bit more fibrous tissue separating that hyperplastic area and that one? So if you want to call this nodular hyperplasia, you can. If you want to call it BPH, you can. If you wanted to call it glandular and stromal being the connective tissue, hyperplasia, you can. These are the common diagnoses you're going to get from pathologists who look at benign but perhaps enlarged prostates. Now, what else do I want to say? Well, let's go in a little bit deeper here just to prove to you they're benign, okay? Let's take all the reasons why these glands are benign. Number one, they're not back to back. They're all separated from each other by a little bit of connective tissue. The nuclei are at the base. There's no nucleoli. And they're hyperplastic simply because there's a little bit more infolding within these lumen. You see that? It's almost a little bit more. I don't know if I would want to call this PIN or early PIN. Perhaps some people would. But in all honesty, this is a benign hyperplastic prostate in a nodular fashion. Both the glands as well as the stroma, the connective tissue between the glands, are increased in size. And whereas the normal weight of a prostate, normal size, is about that of perhaps a small walnut, 25 grams. These can be like 50, 100. They can be pretty big and still benign. Oh, and here, let me ask you this question. if you had this much benign glandular tissue increase, do you think that this patient's PSA might also be increased? Yes, absolutely. So PSA is not specific for cancer, is it? A lot of people think so, but those people are called stupid. PSA is strictly an expression of the protein of these glandular cells. They do not make it malignant. So PSA is a horrible test for screening for cancer. And some of the most massive elevations of PSA that I've seen were in massively enlarged benign prostates and not with cancers. Okay, so much for BPH. Last question. What does the H stand for in BPH? And I'm guessing half of you are going to say hyperplasia, and I'm guessing half of you are going to say hypertrophy. And that's exactly what you're saying. So thank you very much. Let's move on to some last case from Rock Lab. So it's going to take a little bit slower to load. Now, yeah, I get a little bit, impatient waiting for these images to load. But remember, if we were actually putting slides under a microscope and focusing our eyeballs, we would be taking 10 times as much time to look at these lab cases than looking at them with virtual histopathology. And you've probably got an idea what this is, but erase that word from your mind and pretend like you didn't see it. And now we have a prostate. I think you can see generally some glands, but up here the glands may be so packed you could barely see their lumen. And in addition, you see India ink along the surface. So you know that whenever you see India ink on a specimen, it's already a given that it's a malignancy, and the only question is, do the tumor cells go to the India inked margins? So let me ask you this. If these were tumor cells here, and maybe even here, let me ask you this. Are they going to the India inked margins? Yes or no? So can you tell the urologist that he got it all? And of course he'll go back to the family and he'll say, we got it all, because the pathologist told us that the tumor cells did not go to our surgical margins. And that's a massive, massive, massive good news to a family. They've been waiting in the surgical waiting area all night. There's an aunt from Cincinnati and a couple from Idaho, and they haven't slept. They're waiting for the results of the surgery, and the surgeon says, whips off his cap, and he says, we got it all. And they all start crying. They're so grateful, and they're praying. Now, let me show you the bad part, though. The bad part, if you could guess that the reason why these cells don't have very well-defined lumens is because perhaps they're extremely close, back-to-back perhaps, then you would probably know what this was. And I'm going to have to ask you a question at this point. Even at this power, I'm going to ask you a question now. And I'm taking a big chance here, but I want to ask you a question. Is this a slam dunk easy recognition of an adenocarcinoma? Yes or no? Yeah, it is. And look at up here, you got glands that are poorly formed, not much of a lumen. They're definitely back to back. There's pleomorphic as all hell. They look like they may even be involving part of a capsule here. These are just malignant glands, okay? Now, could this be an adenocarcinoma of anything? Could this be colon? Could this be lung? Could this be pancreas? Well, technically it could. Now, somebody brought up an important point here. Somebody said grade 2. And I imagine when you said grade 2, you meant Gleason's grade. Because remember, Gleason goes from 1 to 5. 1 is the best, 5 is the worst. So 2 and 3 are in the middle. Actually, for the person that said 2, there's another person that said 4. So guess what? Guess what this is? If one person said 2 and the other person said 4, what do you think the correct answer is? 3. Absolutely. This was called a 3. But don't forget, one pathologist might call it a 4. One pathologist might call it a 2. Maybe most of the pathologists will call it a 3. So this is a Gleason's 3. So remember, the Gleason's system is not just for one area. The Gleason's scoring system is for the predominant area as well as the not predominant area. And then you add them together. So if there was a 3 all over the place, the final Gleason score would be 6. If this was a 3 here, but then there was a 4 in another place, then the final Gleason score would be 7. And you know, those numbers are very important to urologists, because based on that number, they might do a drastically different type of therapy. And I know Dr. Gleason. He's laughing at everybody, because he says, when I designed this system, I just wanted to give a general quantitative number. But now, the patients and the urologists are hanging their hats on it. So that's why he's laughing. Okay, let me show you something here. I'm going to show you 5 quick cases. And I'm going to say GL1, GL2, GL3, GL4, and GL5. GL stands for Gleason. I'm going to show you each one only for a couple seconds. And remember, in the Gleason 1, you might have a hard time diagnosing it because it looks so much like normal prostate. In a Gleason's 5, it might not even look like glands at all. It's so highly undifferentiated. So the one that we just saw was this 3 here, which is in the middle. But let's look at 1, 2, 3, 4, and 5. Here's 1. Okay. We're going to look at these very quickly. And at first glance, you're going to say, well, gee, this doesn't look terribly malignant. Maybe it's just hyperplasia. But then you look around some more and you look at this area and you could say, yeah, these are still pretty well formed glands, but you know, some of them are back to back. I want to ask you a question too. Do you see this area here? How many of these cells would you say have nucleoli? How many of the glandular cells have nucleoli? What percentage? Yeah, it looks like almost all of them do. Remember, nucleoli are the most important feature. Last question. You see this group of cells here within this gland? What are these cells? Yeah, they're polys. So malignancies can evoke acute inflammation, but acute inflammation does not cause malignancies. Okay, good. Let's look at a Gleason's 2 now. And you're going to say, this one looks worse than 1. This one you could diagnose easy than number 1 because you don't have to look too hard. And look, take a look in here. You're going to see these are very, very easy to recognize as Gleason's 2. Maybe I could find a worse area. Actually, to me, this looks like sort of a 1, but how many of these cells have nucleoli? I wouldn't say all, but I'd say a hell of a lot of them. Okay, and the next question is, once again, just to prove to you this is prostate, what's this junk in here? These are some more concretions, aren't they? So this is a 2. It still doesn't look terribly bad, and there are areas on here that look relatively normal, but this is called a 2. Now you want to find an area which might even be worse. I don't know. Let's see if it's worse over here. Maybe it isn't. We'll just take another quick look. But I could say, even though they call this a 2, I probably might call it a 1. No, that doesn't look too bad either. But it's still, out of 5, that's still one of the better ones. Now here's a 3. Here's the one that we just saw in Rock Lab. And I don't think anybody has a hard time recognizing these as malignant glands, and I'm going to show you why. Here, let's take and look at, there was the India ink on top. Oh boy, that's really neat. Take a look at these glands. These are malignant. Most of them have nucleoli. They're not growing like glands. They don't have secretion. The nuclei are not at the base. Most of them have this. And can I ask you this question here? What is this structure in the middle? What is that? So let me ask you this. Let's say that you had your class sitting there and you're trying to decide whether these glands were malignant or not. And you go, oh gee, I don't know. But then you saw that some of them were growing around the nerve space. Would you have any problem diagnosing it as malignancy then? And that's, sometimes you have to do that. Sometimes you have to go to the outer part of the prostate where the capsule is and look at some of the nerves and see if they're infiltrated. Now here's a nerve and it's not infiltrated, and here's a little nerve too. But I bet you if we looked around enough, and here's a big nerve, I bet you if we looked around enough we'll see some more. Oh, what do we have here, folks? What do we have here? We have nerve spaces that are infiltrated, don't we? There's a nerve that's infiltrated, there's a nerve. So you don't have to debate anymore whether these cells are malignant. They are behaving malignant. Non-malignant cells do not infiltrate in the nerve spaces. I'm glad we saw this one because I didn't see it yesterday when I was reviewing it. This was a 3. Now let's get the 4. This is going to even be worse than the 3. And there are some very specific criteria of how packed the glands have to be. But let's just say the lower Gleason numbers might be hard to diagnose because they look like just hyperplastic glands, and the higher Gleason numbers, like this is a higher one, this is a 4, they might not even look like glands at all. So here, let's take a look. I bet you might even have a hard time, well, you all know this is glandular, but it's not nearly looking like the other glands. And once again, how many of those cells have nucleoli? What percentage? It looks like it's a very high percentage, doesn't it? And look at, even though you might recognize this as a gland, look at some of these things are almost in groups of individual 1 or 2 cells. So this is a high Gleason's one, and let's go down to the last one, which is a Gleason's 5 now. And the first thing you're going to say is, my God, these don't look like glands at all. How the hell can you call this a adenocarcinoma? Well, that's true with most of the high grades. They're so highly undifferentiated. They don't even look like glands anymore. And here, let's zoom in on this area here. Not only do they not look like glands, but they just look terribly, terribly malignant, don't they? Look at that extreme pleomorphism, that extreme hyperchromasia. And look, whenever you see a mitosis that wants to go in more than 2 directions, and they're all over the place, like here, and like here, and like here, then you can say, this is malignant as all hell. Okay, we're done with prostate cancer, but I want to show you something called PIN. And if most of you think this is just hyperplasia when I show it to you, you're probably going to be agreeing with a lot of experts. But if you want to say, well, gee, this does look like hyperplasia, however, it looks like there's a lot of almost like a papillary, a secondary papillary ingrowth into these lumens. This is a little more hyperplastic than hyperplasia because of these little papillary structures growing in the lumen. And you say, well, the cells themselves, they look pretty good. It looks like they're not terribly malignant. This is PIN. Now, the more atypical these cells look, and the more proliferative the growth is, you would be going from a lower PIN to a higher PIN. And in the early days, they used to say PIN1, PIN2, PIN3, but now, thank God, they've come to their senses, sanity, and they're just talk about low-grade PIN versus high-grade PIN. Now, I myself might not call this low, like I thought it was at the beginning, because these cells are a lot more atypical than I had thought they were at first. But the fact is, when you look at them under lower powers, they don't look like cancer, do they? They just look like extreme hyperplasia. And extreme hyperplasia with dysplasia would be called high-grade PIN. And if you would like to call high-grade PIN adenocarcinoma in situ, then be my guest. Okay, we're done with that case too. And let's go now to our very last case. We've seen this before, and I think you're going to get it real quick. And as you can see, it's a prostate. There's glands down here. We don't have to look for a half hour to determine whether they're benign or malignant. Believe me, I looked. They're all benign. But what do you see in the periprostatic venous plexus here? Why is that vein dilated in that one? And not only is it dilated, but it looks like it's not only dilated with blood, but it looks like the blood might even be clotted because you're starting to see some organization of cells. Yeah, these are recently thrombosed periprostatic vessels. Okay, now just as a kind of a quiz again, I'm going to ask you something funny. What is this thing up here? What if there was one glandular cell or group of, what if there was one gland right in this space? What would your absolutely correct diagnosis be? Cancer, right? It would probably be an incidental finding, wouldn't it? And believe me, sometimes that happens. Okay, we're done with prostate. Let's go on to the last area, testis. And we got a few cases here. It wouldn't be fair if we didn't show you the world's most normal testicle. And we're going to do that briefly. We've seen it before. You can see all these are seminiferous tubules. These compressed little spaces lined by flat epithelium is what they call the rete testis or the mediastinum. But let's just take a look at the majority of these little circular structures here. These are seminiferous tubules, right? Now you could see, if you look at some of these tubules, let's look at any area, I guess. The cells in the seminiferous tubules, let's look at a different area to find all the variety of cells. If you see a cell that has a nucleolus, like here, you see the cell right there at the base? That's probably a spermatogonium, okay? It's very undifferentiated. Most of the cells that are still round are primary spermatocytes. Secondary spermatocytes are very difficult to find. They're very rare in humans. But I want to show you two other types of cells. And we're going to look at these cells here between the tubules in the interstitium. And what do you think that these cells are between the tubules? Yeah, these are Leydig cells. Now, can I ask you a question? If Leydig cell tumors are benign and these cells, if the benign tumor cells, would you think a benign Leydig cell tumor is going to have cells that look exactly like this? That's my question. Yeah, absolutely. And can I show you one other kind of cell here that you must not forget either? I'm going to zoom in a little bit more. Do you see how there are cells that look like their nucleus is arranged with pointing towards the lumen, and they have a little nucleolus? Yeah, those are two Sertoli cells. That might not be the world's best one, but I bet you that's one over there. And that might even be one. But they're not the majority of cells. Now, let me ask you this. If most Sertoli cell tumors of the testicle are benign, what do you think the tumor cells look like? They look exactly like this, don't they? Last question. If this was a straight tubule, tubuli recti, rather than a seminiferous tubule, what percentage of these cells would be Sertoli cells? 100%. Absolutely. Because a straight tubule leading from the seminiferous tubules is 100% Sertoli cells. And by the way, what are these cells here that looks like they perhaps are losing a lot of their cytoplasm? These are spermatids, right? And I bet you if we looked, we could even find some perhaps normal sperm. Sometimes you have to, it's a judgment call on whether something is a mature sperm versus a spermatid, but you all know what a mature sperm looks like. You know, a spermatid looks like a mature sperm but has a lot more cytoplasm around the nucleus, and it certainly doesn't look like most of these cells, which are primary spermatocytes. Okay, we're done. We got everything we wanted to see on testicle. Now let me show you this. What would you call this? It's a testicle. You can see some remnants of seminiferous tubules like there or there, but it looks like most of the seminiferous tubules are cooked. It looks like they don't really have viable cells in them. And in addition, you can see that the cells between the tubules, the Leydig cells, they're abundant. You can see them much better, but the actual primary spermatocytes and spermatids and Sertoli cells within the tubules, it looks like they're gone. Yeah, this is the classic picture of testicular atrophy. And remember, no matter what the many causes are of testicular atrophy, you'll usually have an abundance of interstitial cells for the reasons that we talked about, but the actual tubules may be cooked. By the way, I think we saw a couple of tubules though that weren't so bad, but the majority of this testicle is atrophic. Okay, let's find a couple of tubules that maybe are not fully cooked. And, oh, maybe up here we could find a couple. Yeah, that one still has some remnant. There's probably some spermatocytes there. Okay. By the way, can I ask you one last question here? Let's say you were looking very, very carefully at these interstitial cells here, and you happen to find a few little crystalloids in the cytoplasm, like maybe there. Can you tell that that's a little bit of a yellow pigment over there? What would those crystalloids probably be? Testosterone. Remember, the interstitial cells are nourished by the pituitary hormones to produce testosterone. Okay, we're done. Let's take a look at this thing now. This is a, I'm going to tell you something. This is a testicle. And I think you'll see right away it's not a normal testicle. I think you'll see right away it's a tumor. And I think for those of you who have been around long enough, you would probably say, well, gee, it kind of looks like an adenocarcinoma. Maybe it's metastatic. So my question to you is, what tumors metastasize to the testicle? None. Nothing ever metastasizes to the testicle. So if it looks like an adenocarcinoma and you know it can't be metastatic, then you have to know it's primary. Now, what is the primary tumor of the testicle that often looks like an adenocarcinoma? In fact, in the old days, these were called adenocarcinomas. Yeah. Somebody said seminoma. That's wrong. Seminomas look like lymphomas. The tumors that look like adenocarcinomas are embryocarcinomas. What common blood test, what common would be strongly positive in embryonal carcinoma? What substance would you look for in the blood? Yeah, AFP, absolutely correct. Now, let me ask you this. Even though this patient may have had an elevated AFP and it looks like all of his testicle might look like adenocarcinoma or embryono, what is the chance that any given primary testicular malignancy has other elements like seminoma or teratoma or choriocarcinoma? More than half, about 60% of the primary cancers of the testicle have other elements. And look, I'm going to show you another element right now. Take a look at this. What primary malignancy of the testicle is this? Well, if you want to say, I don't know because I can't see the cells, but if you want to say, gee, it looks like there's no connective tissue, it looks 100% viable, it looks uniform, and it looks like there might be lymphocytes. If you're saying that, then the diagnosis is seminoma. Now, seminomas don't have elevated AFPs, but let's say that this seminoma had an elevated AFP. It means that you didn't examine it well enough. It means that if you have a seminoma in a person and they have elevated AFP, most likely they got an area of embryonal somewhere as well. And let's zoom in on these cells, and I want to ask you the key question now. How many of these cells look like spermatocytes? Almost all of them do, don't they? So this is a seminoma that doesn't have many lymphocytes. Okay, remember I said either they have a few lymphocytes, a lot of lymphocytes. But I'm going to show you another seminoma here now. And it's also going to look primarily like a lymphoma, like just small round cells, no connective tissue, no necrosis, no fibrosis. It's going to look a lot like the other one, and you're going to see it in about 10 seconds, I think. And you can see the thumbnail of it over there. So as soon as the screen turns black, you're going to see it in about 3 more seconds after that. Okay, it's black, and now you see it. And I'm going to zoom into this one area here, and I'm going to click it 3 or 4 times. In fact, I'm going to click it 5 times. Okay, and my question to you is, now, in this field, what percentage of the cells in this field look like spermatocytes, and what percentage of cells look like normal lymphocytes? It looks like it's about 50-50 over here, doesn't it? This cluster here is almost 100% normal lymphocytes, and most of them here are, but most of the cells along here are bigger nuclei, and they look like spermatocytes. So let me ask you this. Are the seminomas that have a lot of lymphocytes might even do better than the seminomas that have few lymphocytes? Yes. Okay, now here's going to be the world's easiest question. Why do these cells here look like normal lymphocytes rather than malignant lymphocytes? The answer is because they are normal lymphocytes, but they're still part of the tumor, aren't they? So even though a tumor might weigh, a kilogram, perhaps the viable malignant cells in them might not even be one half of the weight. But nevertheless, these lymphocytes are still regarded as being part of the tumor. Okay, we're done with seminoma. And there is no reliable marker that seminomas express. They don't express the AFP, like the embryonals. They don't express HCG like the choriocarcinomas. But once again, if you have a seminoma that has an elevated AFP or HCG, then you better examine that testicle a little bit more, because you might find elements of embryonal or chorio respectively. Okay. I'm going to show you another one. believe it or not, we're at our hour limit. So I'll just show you 2 more slides. What if I told you this was another testicular tumor? Trust me, this is a tumor of the testicle. You have a wide open space here. You have cartilage here. You look like you have cartilage with osteoid in here. And then you have some kind of epithelial lining here. You got some smooth muscle. So these are all perfectly mature looking elements from both perhaps entoderm as well as mesoderm. And they look totally normal. So what's your diagnosis? Yeah, it's a teratoma. Now remember I told you that most of the teratomas of the testicle are malignant, but most of the teratomas of the ovary are benign. Well, let me ask you this. This really is from the testicle, but is there any evidence that it's malignant? No, because these all look like mature tissue. So mature hyaline cartilage means it's mature. Mature, perhaps GI type of epithelium looks mature. Mature smooth muscle looks mature. These are the maturity of a teratoma determines whether it's benign or malignant. And this is one that is all mature elements, so we're going to call this benign, even though most of the teratomas of the testicle are malignant. Okay, do we want to show anything more on testicle? Yeah, you know what? I'm going to show you something that's so easy you're going to be mad at me for showing it. It's going to be what might look like sort of normal testicle, but then when you look, you can say, well, these tubules don't look that well formed. But then you look at the tubules a little bit closer, and you can see that they're infiltrated with inflammatory cells in the tubules and between the tubules. So what's your diagnosis? It begins with the O, and orchitis. Okay, you remember in orchitis, common causes are things like mumps. You know that gonorrhea can cause orchitis. You know chlamydia can do it. You know that the gram-negative enterics like E. coli and Pseudomonas can do it. If there were granulomas also in this testicle, what would be the #1 disease that you would think of as being the cause of it? Absolutely right, TB. Okay, let's close off. And we're going to take our break now. I was hoping that we could finish faster, but you know what? Who cares? I'm going to go as fast as we want. We're done with our fun, okay? We're going to take our 10-minute break, listen to some more Phil Collins, and then we're going to come back and start in on the female genital tract or the female reproductive system, and at least have one good solid hour of introductory statements and some diseases. So if you have a question during the break, write it down. I'll try to read it and deal with it. In the meantime, let's hear some more Phil Collins for the next 10 minutes. Another great Phil Collins song, and of course we're saving the best one for last. You know, it's always really, really nice to see that as the 2 hours go by, I get more and more students here, attendees rather than less. It's a really good feeling. The only real thought I got during the break is a question which I have to ask you again, and I know I've asked it before, but I have to ask it again because I need more information. I would imagine that some of you, perhaps, that are here live today may have downloaded some of the new MP4s that have been up there. And here's my question to you. I can see a couple of you have already said you did. So, when you viewed the MP4s, were they better than the live sessions that we're giving now? Were they better in quality? Were they better in audio? Were they better in video? And yeah, you're all saying yes, yes, yes. Isn't that amazing? I really am thrilled with those videos because they are superb quality. And I hope it's not a deterrent to come to the live sessions because, you know, I enjoy the live sessions too. So thank you for letting me know that. A couple of people have mentioned that already, but I'm hearing it from a lot more now. I've figured out a way to compress them. After, you know, being in a quandary for months what to do with them, I finally found the magical formula from Dr. Brandon at Chicago Medical School, who gave me the advice, and I'm really, really proud of him. Okay, we're done with that. I guess the next question is, was everybody able to hear me well in the first hour? And I'm seeing a bunch of yeses for that too. So let's start the second hour. And as we threatened you, we're going to start it with a chapter now called Female, now that we finished Male. And we said that like Male, the female was very graphic. It's very logical. and it's very long, so we may spend 2 or 3 sessions on this, but this is a good place to start. Here's our title picture, and if you're wondering who this guy is over here in the middle of all these ovaries and uteruses, his name is Johannes Müller. I guess the 2 dots above the U makes it an umlaut, and if you're German you're supposed to say Müller rather than Muller, and that's who the Müllerian system is named after. The embryologic Müllerian system, 2 paired tubes that insert into the urogenital sinus, but before they do, they fuse, and this fused area here now technically is your uterus, and sometimes it doesn't fuse completely, so you have a septate uterus. Now, if I told you that the ovary, the entire Müllerian system does not overlap with the mesonephric duct. However, the ovary is derived from mesonephros. You know, the same area that gives rise to kidney gives rise to ovary as well. So even though there is an overlap between ovary and mesonephros, the real overlap is in the male system, where the Wolffian duct overlaps a lot with the metanephric and mesonephric duct. Okay, here's our general diagrams. You don't have to go into that. This is a nice embryologic diagram. This is a conceptual diagram. And remember, from the tip of the fimbriae down to the cervix and vagina, that's the entire 1/2 of the Müllerian duct now in a mature woman. It's all columnar lines. Some have cilia, some respond to estrogen and progesterone. You know, some of them don't have cilia, but where the joins with the other side here on the left is in the area that's the uterus. So if you think of the uterus and tube as being different, they're really the same embryologically, except they fuse here. Of course, the cervix here and the vagina, and sometimes this inability to fuse properly or to separate properly can result in not only a double uterus but a double vagina as well, or even a septate vagina. Okay, and you'll notice how the ovary still here may have some mesonephric remnants. They're very, very common to see little peritubal cysts. Some of them are mesonephric remnants, and some of them are a few other things. So these are the topics we're going to deal with. Classically, I could whip them off in 2 sessions. Most likely we won't be able to do all of the first session today, but maybe we'll catch up on the next session. Start out with the vulva, and the vulva can be defined as female external genitalia, or more precisely anatomically, everything anterior to the introitus, which is the very opening of the vagina. And if you wanted to classify vulvar diseases in our usual way of degenerative, inflammatory, neoplastic, you can, because that's the spectrum of common diseases. A Bartholin cyst is, I guess you'd call it a benign tumor. It's not really a neoplasm, but it's a cyst, it's a lump, so in that sense it's a tumor. We'll be talking about inflammation of the vestibular glands, called vestibulitis. We're talking about degenerative / inflammatory changes of the skin or epithelium of the vulva, generally the large category of lichenoid or lichen diseases. And then, of course, it's not surprising that the tumors are benign and malignant, like we've classified them everywhere, and the benign tumors, like the penis, are condyloma. They're all HPV related, and malignant tumors from dysplastic epithelium, which we'll call VIN for vulvar intraepithelial neoplasia, all the way to severe VIN, which is carcinoma in situ, and then of course infiltrating as well. So those are the spectrum of vulvar diseases. Here's a Bartholin cyst. A Bartholin gland is the female counterpart of what we saw the other day as the bulbourethra or Cowper's gland in men. They can become inflamed. They can also have obstruction in their ducts, and when their ducts are obstructed they can become enlarged, and that's called a Bartholin cyst. Okay, these cysts can be secondarily infected. They usually do not need surgery. It depends on how big they are and how resistant they are to more conservative treatments. But every now and then you'll hear a woman that had a Bartholin cyst removed. And of course, you can also guess, goes without saying, they never become malignant because they're just cysts. They're just obstructed ducts of the Bartholin glands, which are also called the greater vestibular glands. Now, there's another set of vestibular glands which are not called the lesser vestibular glands. They're just called vestibular glands. And you could have an inflammation of those glands as well. Call it vulvar vestibulitis. And usually those are inflammations of not the greater vestibular gland, which is in the posterior wall of the vagina, but the other vestibular glands in the upper or anterior wall of the vagina. So when they become inflamed with a variety of perhaps the usual types of superficial pyogenic bacteria, that can produce vulvodynia, or pain on the vulva. Okay, if this would resulted in painful intercourse as well, they would call that dyspareunia, or painful intercourse. The actual skin of the vulva can become inflamed. It can become fibrotic, and the general term given to the family of inflammatory and atrophic or even hypertrophic skin conditions in the vulva are called the lichen, L-I-C-H-E-N disorders. Now, the classical one is called LS&A. A lot of the OB guys just say LS&A, and that means that the skin is sclerotic. In other words, there's a lot of fibrosis in it, secondary to chronic inflammation. But the overlying epithelium is also atrophic. So that's what the LS&A stands for. Lichen, referring to the skin disorder. I think in Greek it means crusty or something like that. And sclerosis means fibrosis, and atrophy means atrophy of the epithelium. Now, there's another lichenoid disorder of the vulva in which the epidermis, epithelium, is not atrophic, but it's hypertrophic, or perhaps hyperplastic is a better word, isn't it? That would be in the family of lichen simplex chronicus. Now, lichen simplex chronicus can occur in many other portions of the skin, okay, not just the vulva. But LS&A is pretty much specific for the vulva. Now, the reason why I'm separating these lichenoid disorders into atrophic and hyperplastic is because the atrophic ones never turn into cancer, but the hyperplastic ones do have a statistical likelihood of possibly being associated with cancer. Now, the common features of both of them are fibrosis and inflammation. Here are some pictures. I think you can see that the vulvar skin looks a little raw. It looks a little inflamed. Perhaps it might look thickened or atrophic. And these are all the various features of LS&A clinically. Pathologically, you could see that there is a stratum corneum here. You can see part of a hair follicle, so you know it's skin. And then you can see perhaps a little bit of edema in the superficial dermis. And in the deeper dermis, there's inflammation and fibrosis. I think that is pretty obvious right now. But I wanted to tell you that this other type of lichenoid disorder, which you can see elsewhere in the body, is your lichen simplex chronicus. And look at, in here, the epidermis is not atrophic, but it's actually hyperplastic or hypertrophic. Not only is there an increased stratum corneum, but there's an increased layer of your prickle cells, or acanthosis as well. This is hyperkeratosis, which is thickening of the stratum corneum. Here's acanthosis, or a hyperplasia of the stratum spinosum. And even though it is agreed upon that some of this hyperplasia is secondarily due to scratching and inflammation, it still has a relationship, as a possibility to become malignant. Now, I know what you're thinking. You're thinking, well, you know, scratching doesn't cause malignancy. I know it doesn't also, but I think you should know that hyperplasia of any substance is what we call the promoter for carcinogen. So if there was initiated there, you know, a real carcinogen, and the skin had increased turnover due to any cause, whether it's mechanical or hormonal, that's the reason for the statistical. So a lichen simplex chronicus, or any lichenoid disorder in which the mucosa, the epithelium, is hyperplastic, is going to be much more carefully watched and followed by the OB doctor rather than just a regular atrophic one. So here's something to remember. The hyperplastic ones are potentially, I guess I should put that word in quotes, because if I said pre-malignant, it would just be a terribly lie. We'll call it potentially pre-malignant. Okay, here's another actual tumor now of the epidermis. And I think you all know what this is because we saw this exact same thing on the penis. It says these little cauliflower type growths. These are condyloma. And if you remember microscopically, the condyloma, the cells may have clear spaces around them, which is called coilocytosis. It's a thickening. And these are benign. They're all HPV related, HPV caused. And if the condyloma can not only be on the vulva, it could be deeper inside. It could be in the vagina. It could be on the cervix. So if this woman had a pap smear and they found a lot of cells that had little spaces around the nucleus, like you can see them here histologically, then you would probably think this woman had HPV exposure and maybe even, you know, condyloma. So coilocytosis can also be probably called condylomatous hyperplasia as well. Let's move into the cancers and the precancers now. And they're HPV related too. So could condyloma be part of a VIN? Yeah, I guess it could, because they're both premalignant surface processes, as well as condylomas can become atypical and eventually result in a squamous cell carcinoma. Now, just like we said, PIN for prostate intraepithelial neoplasm, and like we'll be talking about CIN for cervical intraepithelial neoplasm. You also have VIN, and the V stands for vulva, but the V can also stand for vagina. So there's CINs, VINs, PINs all over the place. Believe it or not, in the endometrium there's even a EIN for endometrial intraepithelial neoplasia, and this refers to the family, the spectrum of changes in the epithelium which lead to in situ carcinoma. All of the severe INs, whether it's a severe VIN, CIN, PIN, VIN, or EN, it would probably also be called adenocarcinoma, or I'm sorry, carcinomas in situ. So dysplasia of the vulva would be called VIN. If it's severe dysplasia, you could call it carcinoma in situ, and you all know what happens after that. We have infiltration. So here is a vulva, and you could tell that there's some thickening here and some redness, and I don't know if you would be suspicious that that was cancer or precancer or VIN, but if you did the biopsy and you looked, not only is there increased hyperplasia of the cells, but there's also occasional atypical cells. So this is VIN. And remember, high-grade VIN, whether it's vulvar or vaginal, could also be called carcinoma in situ. But take a look at that really nice basement membrane, how sharp it is. Nothing has infiltrated. Of course, if you saw a tiny nest of infiltration, you could no longer call it IN, because it's no longer intraepithelial. It is now infiltrated. Speaking of infiltration, I think you probably have a good idea what this is. This is a vulva, unfortunate patient, and it's no longer just thickened skin. You can see that there is some major growth here, and it involves most of the vulva itself. You could probably imagine it's a destructive process. And if you're suspecting it's a cancer, I think you know almost certainly what kind of cancer it has to be. There's a squamous cell cancer, okay? It's an infiltrating squamous cell cancer. You can see all the infiltrating nests over here. And I'm going to ask you that same question again. I'm popping open the window and I'll say, does anybody here see any pearls? No. So it's not a well-differentiated squamous cell carcinoma either. Now, if we took a deeper look at this, and we will when we get to lab, and you can see there's some intracellular bridges, so we know they're squamous cells. You could probably call them then at least moderately differentiated, but it doesn't matter. At this stage, it's infiltrated, doesn't it? And these actual definitions of well, poor, or moderate don't really mean much in terms of this patient's prognosis. The more important thing is the staging. Well, how far has it spread? Here's another specimen, a radical vulvectomy. Believe it or not, these are still done occasionally. This happened to be a malignant melanoma. You can see some black pigmentation already. As horrifying as this may seem, this could actually have possibly saved the woman's life. And actually, you don't really know it's a melanoma because that black stuff could be old hemorrhage. But if you actually took a section through it, you could see that the cells are big, large, and let's see, I'll probably find, oh, there's not too much pigment here, is there? I probably should have found one that had more pigment. There's some pigment over there. And look, there's some pigment over there. So I guess you have to decide whether that's hemosiderin, bile, or melanin, right? Now, I don't think it's hemosiderin, because if it is, it would be inside of macrophages rather than malignant-looking cells. I don't think it's bile. There's no reason to have bile in that area. So you know this is melanin. And if you wanted to really prove it was melanin, whether it had good pigment microscopically or not, you would also do a stain for either S100 or I.mp4. These are the immunostains that prove that even if you can't see melanin well, grossly or microscopically, there are certainly melanin precursors in there. Okay, let's go to the vagina. We'll talk about some of the congenital anomalies, and then our usual triad of inflammatory, neoplastic, and the vaginal disorders kind of parallel the deeper ones, because you can have a parallel uterus with a double vagina as well, or just a double uterus, or even a septate uterus, and it looks like it's double only in the upper portion rather than the lower portion. That could happen in the vagina as well. Inflammatory diseases, vaginitis in a premenopausal woman. Most of the vaginitis is STD related, you know, chlamydia, gonorrhea, trick, and a whole bunch of other weird organisms. In a post-menopausal woman, most of the vaginitis is due to atrophy, or what they call atrophic vaginitis. And, not surprisingly again, in the realm of actual neoplasms now, most of the benign squamous tumors, remember the vagina is lined by non-keratinized squamous epithelium, are condylomas. You can also have tumors of the accessory glands, a hidradenomas, but condylomas are the majority of benign squamous proliferations, and not surprisingly, the malignant proliferations are also squamous, preceded by dysplastic changes called VIN, severe VIN being squamous cell carcinoma in situ. And you know what it does after that? It infiltrates. So let's look at the congenital possibilities. Well, one possibility is that the hymen never becomes perforate. So if a hymen remains imperforate when menstruation starts, then you're going to get all that collection of blood in the vagina where no place to go because it's blocked off by the hymen. So it's hematoculpose, or blood in the vagina. Technically, you could get vaginas that just don't develop very well. There could be very, very small or atretic, atresia, or they could be completely gone. They could be agenesis. And as you might guess, agenesis or absence is probably more rare than just atresia. Just like you can have a septate uterus If the Mullerian ducts don't fuse properly, that can also extend into the vagina as well. And an extreme example of a septate vagina would be a double vagina with double uterus, called a didelphys. You probably never heard the term didelphys in your life, and actually I don't think I've ever used it in my life either, except to teach it. Here is a example of a atretic or absent vagina. It looks like there's nothing there, or it's very, very small. And of course, this double uterus here looks like it has only one cervix, so most likely this is also going to have one vagina. But if this failure to fuse extends to cause a double cervix as well as a double uterus, it may extend also and cause either a septate or double vagina as well. Inflammation. Well, 90% of the vaginitis in premenopausal women is STDs. Okay, so you can say that trick is probably the most common thing here, trichomonas. Well, hold on, I said it was the third most common cause, so let me be consistent. Regular bacteria is the single most common cause of vaginitis. Now, you can have overgrowth of species that may normally be there, like Gardnerella, Mobiluncus, even Mycoplasma, and the Peptostreptococcus. These are the four common bacterial causes of vaginitis in premenopausal women. Also remember, pregnancy is associated with the vaginitis. Intrauterine devices are associated with all kinds of vaginitis, not only bacterial but also fungal, and also trick as well. Candida. We've said time and time again that Candida is a fungus which loves to hang around non-keratinized, moist, stratified squamous epithelium anywhere in your body. So Candida is also a very, very big cause. Albicans is number one, but there's a few other species. And the more that woman is immunocompromised, or the more she may be on oral contraceptives or IUDs, these are all even further risk factors for Candida. Okay? It could just be a immunocompromised state due to diabetes. But what about somebody that's really immunocompromised, like HIV, or somebody that's on chemo? These are all settings for fungal or candidal vaginitis. Trick, well recognized as a STD, are little flagellated protozoans. You can see them very well. You know, the OB guys can just do a little wet prep. They could do a smear, they could put a drop, they could put a little stain in there, and they can see the tricks very, very easy. They may even still be alive. And they can infect the not just the vagina, but all the way into the endocervix, the urethra, the Barthen's glands. It's also a very common cause of vestibulitis as well. It's all STD, and it can be identified in most of their male partners. And I'm going to show you a nice picture of trick here. This is from a wet prep. You can see it's a protozoan, and if you're lucky, you'll see these little red flagella on it. And of course, what you'll never see is the scanning electron microscopy. But if you're an OB doc and you do a wet prep on a woman with vaginitis, premenopausal, perhaps it has the usual risk factors, you're likely to see trick. Okay, let's talk about vaginal neoplasms now. No different from anywhere else we've seen. The changes of dysplasia, which can lead up to an actual infiltrating squamous cell carcinoma, is called VIN. But in this case, the V does not stand for vulvar, the V stands for vaginal. A severe VIN could be regarded as in situ, or it can infiltrate. Now, you can also have glandular hyperplasia, even leading to adenocarcinoma. And these are primarily in women, in the children of women. that have been exposed to diethylstilbestrol. That's a very, very well-known, documented fact as well. But let's go into the actual squamous one first. I think you could see in this vagina we have redness, we have plaques. You're probably worried that these little white plaques might be dysplastic or cancer. And if you think that it's all related to HPV, again, you're absolutely right. Microscopically, there's absolutely a normal vaginal mucosa. You could see perhaps a very, very mildly keratinized surface, just a few layers of squamous. And then you could see there are more layers of squamous. You can see it's much greater keratinized. This might be seen as one of those little white plaques. And in addition, you could see atypical nuclei. They're pleomorphic. They're hyperchromatic. So, if you thought this was just a little bit, you would call this low-grade VIN, or perhaps VIN1 if you wanted to give it a number. If you think this was severe to the point where you're thinking it's probably very close to carcinoma in situ, then you would call it high-grade VIN, or give it a 3, let's say. And in my opinion, if this is normal vaginal mucosa here on the left, my question to you is, what would you call this? Low or high-grade VIN? Well, I'll tell you what the result is. I see some people saying low, but I also see an equal number saying high. So how about if we compromise and just call it medium, like maybe a VIN2? I personally would have led a little bit more towards a 3, but I think it's a little bit more than low here. Okay, somebody said high grade. I would say it's not low. I would call it a 2 or 3, depending on, you know, how much coffee I had that morning when I'm looking at the slide. And there'd be a lot of variation about this. Here's another vaginal neoplasm. Doesn't look flat anymore. It looks, from the point of view of the OB guy doing colposcopy, this is an actual tumor. If you do a smear on some of the cells, you can see they're big, dark, ugly, malignant as all hell. This is an infiltrating squamous cell carcinoma. Of course, from the cells here, all you know is that they're malignant cells. From the point of view of the examination of the vagina, you could say it looks infiltrating. And I think the histology would almost always bear you out that these malignant cells here, as well as being on the surface and perhaps scraped from these are also infiltrating as well. Okay, let's get into another interesting thing. When we talk about the cervix, we're going to talk about the concept of squamous metaplasia. Remember, we said whenever there is a junction between the columnar and the squamous mucosa, like the lower esophagus or the lower rectoanal junction or the cervix, whenever there is some inflammation in the columnar or glandular part of that, it may react by becoming squamous metaplastic. That can also occur in the lower vagina, which is normally squamous but may also have some glands. You can also see squamous metaplasia of the glands. And look, here's a cervix that looks redder than usual, and there's the external os of the cervix. And in this case, you have a lot of squamous metaplasia going on in those cervical glands as well. Now, the reason why I'm pointing this out is, let's say that you were inexperienced and you're looking at this for the first time, and you could see that there are glands here, but there are also surface epithelium of squamous cells, but it looks like some of these squamous cells are going into the glands, like here, and like here, and like here. So unless you're experienced, you're going to be very, very worried, and you're going to wonder if this is a well-differentiated squamous cell cancer infiltrating those glands. But what it really is just squamous metaplasia, not only involving the surface epithelium, but also the glandular underlying glands as well. Now let's say that you saw this also in a vagina, and you know this isn't squamous. You know it's glandular. And in addition, I think you will all agree that these are not well-formed glands with lumens separated by fibrous tissue. Some are back-to-back, and the nuclear atypia is unbelievable. That might be an abnormal mitosis there. There's a large dark cell. So let's say that this was biopsied as tumor of the vagina. So what's your diagnosis? Let's make it simple. Not cancer is one choice. Squamous cell cancer is the other choice, and adenocarcinoma is the third choice. Yeah, it's adenocarcinoma. Now, can I ask another question? Because a lot of these cells here look like they have washed out clear cytoplasm, might some people want to call this maybe a clear cell carcinoma as well? Actually, somebody already did call it a clear cell carcinoma. Okay, so this is now adenocarcinoma. We've seen the infiltrating squamous cell carcinomas. And what are we going to do next? The very next thing we're going to do is to show you a third type of malignancy, which is rare, and it's always in young patients, perhaps newborns even. And this is called an embryonal rhabdomyosarcoma. And the first thing you're going to say is, it looks like it's a bunch of grapes just kind of growing out of the vagina. And I think in Greek the word batrioid means like a bunch of grapes. Like you've seen those pictures of the Greek gods eating the grapes. That's batrioid. Well, a batrioid rhabdomyosarcoma is the old name for this tumor because it looks like grapes. It's probably better classified now as a sarcoma batrioides or batrioid sarcoma, or the best word is embryonal rhabdomyosarcoma. And from its name, you know that it is probably derived from the same cells that would give rise to skeletal muscle cells. Now I know what you're thinking. You're thinking, skeletal muscle doesn't have the capacity to divide, so how could it form a sarcoma? And you're absolutely correct. Mature skeletal muscle cells cannot divide, so they can't form tumors, right? But what about these skeletal muscle precursors, the more primitive cells that divide to become skeletal muscle? They can form tumors, and when they do, they're called rhabdomyosarcomas. So this is a childhood embryonal rhabdomyosarcoma, and if you want to put the word batrioid somewhere in there, you're probably describing it even better. Okay? Let's see where we are. It's 10:49. Okay, let's take a deep breath, because we're finished with most of the vaginal and vulvar common diseases. And now we're going to talk about a huge area, which seems like it's most of female pathology, is the cervix. So take a deep breath. You've done a good job. We've been listening carefully. And we're going to be now dealing with the cervix. And I think I should at least make an introduction into cervical diseases, even though I know we won't get the time to describe all of them. We're going to show you a normal cervix. You've already understood that whenever the normal glandular part of the cervix becomes inflamed or irritated in any way, it reacts by forming squamous elements. And you know that the normal squamo-columnar junction is at the external cervical os, and the entire endocervix and internal os are lined by columnar epithelium, whereas everything inferior to the external cervical os is lined by squamous epithelium. You can have inflammations. You can have benign, totally benign overgrowths of normal mucosal tissue called polyps. You could have squamous neoplasms, also all HPV related. The concept of dysplasia, if you'd rather call dysplasia CIN for cervical intraepithelial neoplasia, you can. Or if you would rather use the newer cytologic term called SIL for squamous intraepithelial lesion, you can. And of course, you know that the bottom line, the endpoint of all of these dysplasias or CINs or SILs, whatever you want to call them, is infiltrating squamous cell carcinoma, formerly one of the biggest cancer killers of women until the development of the pap smear. So can you say that Dr. Papanicolaou, very nice pathologist, cured one of the most common malignant killers of women? Absolutely. Here's a normal cervix. Now, I think you can get a really good feel just from looking at this cervix from the point of view of the colposcopist. This is probably an OB doc, GYN guy, that has a little scope there. He took a picture. And do you see this nice little line here? I'm going to be driving along the line, which seems to separate a thicker, shinier type of mucosa from a more mucousy type of mucosa, which is redder. This is the squamo-columnar junction. So all of this stuff over here and over here and over here is squamous, and here's the precise area where the squamous then at the external cervical os becomes columnar. Now the first thing that you'll notice, it's never ever ever a precise circle. And in addition, look at, there's even a little skip area over there. This is perfectly normal. The squamo-columnar junction is not a perfectly normal dividing zone. There's skip areas, there's irregular signs and waves, but you know that everything you see in this picture is squamous. And then once you generally look into the external cervical os, most of this more mucousy or pinker or redder stuff, thinner stuff, is columnar. And that's probably one of the most normal squamo-columnar junctions you'll ever see. Look, here it is microscopically. All of the stuff here on the left, absolutely, is the most normal squamous epithelium you'll ever see, except it doesn't keratinize, does it? But you can see intercellular bridges. You can see how the squamous cells generally mature from a more columnar sort of appearance to a more flattened or cuboidal and finally flattened out squamous on the top. And you can say right here, precisely, right where my arrow is, okay, this is the junction between squamous cells and columnar cells. And look at these columnar cells are really neat. They're all standing up nicely. They all have a nice border here. They have nuclei at the base. They're one that happens to be dividing, but it looks like it's a normal mitosis. Okay? What if I told you that most of the carcinomas of the cervix started out at this very active growth zone here? Most of the squamous cell carcinomas of the cervix originate in this squamo-columnar junction. But we don't care about that for now. That just happens to be a fact. Now, another thing I want to bring to your attention is that normally in the cervix, especially in the so-called junction between squamous on the left and columnar on the right, you normally see a good sprinkling of inflammatory cells. You see a lot of lymphocytes. You see a good number of plasma cells. Oh, you might even see some neutrophils every now and then. Remember, this is an area which is subject to a lot of inflammation. And also remember, technically, it is the gatekeeper to the abdominal cavity. Because remember, if you take that fimbriated end of the fallopian tube and you travel down it from the abdominal cavity into the uterus, This is basically the end of the uterus, isn't it? At the cervix. So there's normally a lot of protective cells there, making antibodies and fighting off potential pathogens. This is the world's most normal Pap smear. Most of those flattened cells we saw at the cervix are now, rather than stained with H&E, are stained with the Papa-Nicolau stain, which is similar to H&E in some respects. The nuclei are still bluer and darker, and the cytoplasm is still lighter, maybe pinker or greenish. This is probably a nice, normal Pap smear. But here, I have to ask you 3 questions. Number 1, is this woman probably premenopausal or postmenopausal? Okay, we got the right answer here. Everybody's saying pre. The reason why we're saying pre is because most of these cells are maturing all the way into flat squamous cells. So we know this woman is premenopausal and she has a good estrogen level, therefore, correct? Now let's say that we did a Pap smear in which most of the cells were not these nice big flat cells, but they looked more like this, where they had bigger nuclei and less cytoplasm. Would you say that could possibly be a post-menopausal? Yeah. So here, this is the final question. Like hell it is. I'll probably ask you more after this. Do you think that a Pap smear is a good way to indirectly measure estrogen level? By looking at the number of these flat cells? Yeah, these are called superficial cells, okay? And the ones with lesser cytoplasm are either called basal cells or pre-basal cells. And depending on the ratio of those, you can actually estimate the woman's estrogen level. Now, another thing I want you to remember about this so-called normal Pap smear is that there's a lot of inflammatory cells here, aren't there? You see all these neutrophils? Almost all of these cells are neutrophils here and here. So don't ever make the mistake of calling a cervicitis or an infection just because you see a lot of neutrophils. They're normally there. Another thing is, you can occasionally see a lot of little bacteria there. That might even be a bacteria there. You can see cockle bacteria. You could see rods. That's probably a little rod there. Look, I bet you these are little rods over here too. Just because you see bacteria, don't call it an infection. You normally see healthy, normal bacteria on a Pap smear. The only thing you care about is the size and staining and shape of the nuclei. I'm going to show you one last slide. No, I'm not going to show you one last slide. We're going to go home now. It's already 10:59. But I think we had a good introduction into the cervix, and we're going to seeing a lot of cervical slides in lab as well. So we'll call it a day for now. And we're already on 32 out of 136. So maybe in the next session we'll finish the entire discussion of female genital tract. Let's see if there was a question there somewhere. I saw somebody wrote a question. Let's pop out the question box. Somebody said, how would you differentiate BW squamocolumnar junction as squamous metaplasia of columnar epithelium? Well, that's an excellent question, and the answer is sometimes you can't, because squamous is squamous and glandular is glandular. However, squamous metaplasia can be diagnosed when you actively see it replacing columnar, especially if it's within a gland. That's one way for sure. Otherwise, if you see squamous cells, whether they're on Pap or whether they're on tissue, that's squamous. You don't know whether it's squamous metaplastic or inherent squamous. Okay, hope that answers your question. What I'm going to do now is see if anybody has their hands raised by going into our other thing here. Still a lot of people here. We'll see if anybody has hands raised. Nobody does. So we're going to call this a day. So we're already at the hour. We'll finish up female in the next session. Thanks for coming by. And my last Phil Collins song, I'm going to be talking over it while it starts. Because even though you'll start to hear a little bit of music now, it doesn't really start up for about a minute. So I want to tell you something. This song is called Another Day in Paradise. And perhaps some of you have wondered, where is paradise? And you want to know where paradise is? It's right here on earth. And if you ever want to see the King of Paradise, look into the eyes of the people on the street that are begging you for help. Thank you very much. Rock on, you buzzards, in paradise.